Good afternoon, colleagues, and welcome to today's Sidney Sachs Awards ceremony. I'm John Gregg, Chief Executive of the Australian Healthcare and Hospitals Association, the national peak body for public and not-for-profit hospitals and healthcare providers. Before we begin, I would first like to acknowledge and pay my respects to the traditional custodians of the many lands on which we meet and recognise their continuing connection to land, water and culture. I live and work in Canberra, on the land of the Ngunnawal people, and I pay my respects to their elders past, present and emerging. I also extend my acknowledgement to any Aboriginal or Torres Strait Islander colleague on this webinar today. In today's virtual Sidney Sachs Awards ceremony, we will hear from our 2021 medalist, Professor Jeffrey Braithwaite. There will be an opportunity for questions at the end of his presentation, so please send your questions through the Q&A function. I would now like to welcome Australian Healthcare and Hospitals Association Chair Gillian Skinner to present the 2021 Sidney Sachs Medal. Thanks, Gillian.
Thank you, John, and good afternoon, everyone, especially you, Jeffrey Braithwaite. I'd also like to start by acknowledging the traditional custodians of the land on which we meet. And from my part, for the moment, I'm on the land of the Worimi people, and I'd like to pay my respect to elders past, present and emerging. For over 30 years, the Australian Healthcare and Hospitals Association has honoured outstanding health leaders for their contributions to the development and improvement of the Australian healthcare system with the annual Sidney Sachs Award. Dr. Sid Sachs is an icon of the Australian healthcare sector, with his greatest contribution being the development of Medibank, the predecessor of Medicare. In the very early 1970s, he convinced then Prime Minister Gough Whitlam to work with the states to provide Commonwealth funding to public hospitals. This, together with the medical benefit scheme and the pharmaceutical benefit scheme, is the foundation of the universal healthcare system that so many Australians benefit from today. Much like Sid Sachs, our 2021 medalist has made a lasting impact on the health and wellbeing of Australians. Our 2021 medalist is Professor Jeffrey Braithwaite. Jeffrey is a world-renowned researcher who has dedicated his career to improving the delivery and safety of the Australian healthcare system and the experiences of patients and providers within the system. This is demonstrated through his role in contributing to the establishment of the largest health services research institute in Australia, the Australian Institute of Health Innovation at Macquarie University, where he currently leads the Centre for Healthcare Resilience and Implementation Science. Jeffrey has made significant contributions to researching the culture and structure of acute settings, of leadership, management, and change in health sector organisations, in patient safety, accreditation, and the impact of restructuring of health services. He co-led the Care Track Australia project, part of the NHMRC Council Program grant that examined the appropriateness of the care provided in Australia. He's well known for bringing management and leadership concepts and evidence into the clinical era, and he has been published extensively on topics relating to organisational, social and team approaches to care. He's well known internationally for his role in providing the research evidence to improve care for both adults and children, and fundamental principles for the governance of health systems. His work on health reform across the world and in new models of care to provide care more safely is used in many countries and health systems. Jeffrey is a fellow of the Australasian College of Health Service Management, a fellow of the Australian Academy of Health and Medical Sciences, and an honorary fellow of the Royal Australasian College of Medical Administrators. He has also received international recognition through appointments as President of the International Society for Quality in Healthcare, a fellow in the distinction grade at the Faculty of Public Health at the Royal College of Physicians in the United Kingdom, and fellow of the Academy of Social Sciences in the United Kingdom. And on a personal level, I want to note this. I have known Professor Braithwaite for many years, probably some 20 years ago. He assisted me in a consultation with nurses. I was developing policies, and nurses from all over New South Wales had agreed to come together for a half-day forum to share their concerns and ideas about how to solve them. They came from all areas of nursing, ranging from tertiary level acute care to drug and alcohol, community nursing, mental health care, paediatric and geriatric care, from a wide range of skills ranging from students to dons. There was a real risk that the forum could go pear-shaped, that it could end up as a talk fest, which was dissatisfying to all. But with Geoffrey's expert guidance as a facilitator, his empathetic manner and positive direction, he had the room animated and engaged, and I ended up with new insights, firm friends, and helpful policy ideas. I've watched the endeavours with which he has been engaged with great admiration, and always reminded of the his special ability to imagine, to inspire, and to lead innovative solutions to medical practice, whether it be in the field of clinical practice or models of care. Geoffrey Braithwaite is a skillful leader. He has the ability to calm troubled waters. He has the capacity to help others identify their concerns and inspire them to develop solutions and then to implement them. So it gives me great pleasure, both personally and as chair of the Australian Healthcare and Hospitals Association, to virtually present the 2021 Sidney Sachs Medal to Geoffrey Braithwaite. Congratulations, Geoffrey.
Geoffrey Braithwaite, Professor of Health Systems Research and Founding Director of the Australian Institute of Health Innovation at Macquarie University. So I was led to a career in health services research through an interesting pathway, and I guess anybody who's a health services researcher goes through some sort of convoluted pathway. You don't wake up in the morning thinking, I want to drive a fire truck, or not, and then thinking, I want to be a health systems researcher. So at first, while I trained in psychology, I didn't really become a psychologist. I went to work in the health system as a human resources practitioner, and then later as a general manager in healthcare, in hospitals and local health districts. But really, what beckoned was teaching and research and making a scholarly contribution. And I started at University of New South Wales and then came across to Macquarie. And now I do a variety of health systems, health services research studies, nationally and internationally. The Institute was formed out of some existing research centres in university speak, small groups of scholars and PhD students and professors who all work on a particular issue. So there were some pre-existing centres at University of New South Wales that we amalgamated together into this bigger institute structure. There was Enrico Carrera's Centre for Health Informatics, the centre I was running at that time, and also later the centre that Professor Joanna Westbrook leads, who came together. And then at University of New South Wales, we were very successful. And then we moved to Macquarie for some new opportunities. So the early formative periods at UNSW were really good at creating the centre, the centres and the institute that we have now at Macquarie University. So what does it mean for me to be the recipient of something as prestigious as the Sidney Sachs Medal? Well, firstly, I'm deeply humbled. But I want to say this, you know, when people receive awards like this, it looks like it's an individual award, but you know, it's not. It's a team game. This is actually not an award for me, even though I'm the recipient. This is an award for all the people I've worked with and who have helped me. I'm thinking of my immediate family. You can't, you know, it takes a village. It's not an individual award in reality. So my immediate family, the other directors of the Institute who work with me and who nominated me, Enrico Coira and Joanna Westbrook. The place I work, the Institute, and you can build concentric circles around that. All the people I've worked with in various parts of the health system and universities and collaborators across this university, Macquarie, and other universities. My faculty, which is a fantastic place for our institute to be, Faculty of Health, Medicine and Human Sciences. There's people internationally who I've worked with, policymakers, clinicians, leaders, managers, patients and patients groups, fellow researchers and educators. So really, this is their award. I just happen to be the person picking it up. So I'm deeply humbled. It's fantastic that I've received it, but it really does take a village. And I'm very grateful to all the people I've worked with over the years. And I'm especially grateful to the AHHA, which I've long admired, and the board of the AHHA, especially Gillian Skinner, the chair of the board, who I've been a fan of for decades.
I think we're going to now hear a little bit more from the recipient, Professor Braithwaite, and then we'll take questions and the answers at the end of his presentation. So go ahead, Jeffrey. Thank you.
Thank you, John. Thank you very much indeed. So I'm a professor. I've got some slides. Actually, it's very hard to follow yourself. So you don't often do that at conferences and in educational sessions. So I'll do my best to try and make this work seamlessly. So I'd finished that that video that AHHA did with me for me, talking about it takes a village. So I've titled this talk, "It's all about we, not me," and I hope you'll enjoy it. So checking my slides, it's changing. And the Institute is a special place. We do health systems research. Gillian, are my slides changing? Great. And like our faculty, our logo is Heal, Learn, Discover. We spend a lot of time in discovery because we're researchers and also learning and teaching. But the end result is always for us, how do we help people in the system? How do we help patients? That's about healing. So as I said, there's three of us who co-lead the Institute, myself, Enrico Coira, and Joanna Westbrook. And then around us, we each run a university center. And then around us, we have various centers that we've attracted along the way across time. Medical Research Future Fund and National Health and Medical Research Council grants and centers. And so the Institute's got about 200 people associated with it in Sydney, in Adelaide, and also across the world and across the country. Firstly, to my family, to this list of people, thank you. It really does mean so much to me that you have contributed to my intellectual development and my support structures. And to the nominees and award panel, which was the Gillian and the board, and Enrico and Joanna. So first things first, you gave this award and medal for my contribution to healthcare. But according to a request that I received from the Open Journal of Environmental Biology, I have the expertise to review a manuscript entitled Western Sudan Arab Camel Hides, Attributes and Leather Quality Characteristics. So please don't pigeonhole me as just a health services sort of person. It appears from this journal's invitation I have much wider interests than healthcare. Truth is, the teamwork is at the heart of achievement. You know that, I know that, and this award is predicated on that. And if you want another aphorism, the strength of the team is each individual member, and the strength of each individual member is the team. Here's some of the teams that I work with. Here's some people from the Institute giving you all a wave, many of whom are on the line. Not everyone, but some of us. Here's the Macquarie University Executive Group, led by another colleague of Gillian and mine, Professor Bruce Doughton, who was instrumental in bringing us across and approving us to move from UNSW to Macquarie, and also his executive team, who we rely on so much for support. Here's the ISQA board. I'm the president of the International Society for Quality, and that gives me a gateway into lots of countries, low, middle income and high income countries. And it's fantastic and a real privilege to work with these folks across the world. Here's my own board. Enrico, Joanna and I report to a board chaired by our executive dean, Professor Patrick McNeil. And here is the board, who's just about the who's who of the health system, to be frank. A fantastic group of people to support and advise us. Here's some acknowledgements from my own research institute, the Centre for Healthcare Resilience and Implementation Science, Chris. Thank you to all of you. And from CASA, Joanna's research group, which is interested in health systems and aged care and informatics. And some people from Centre for Health Informatics, Enrico's group, some of the people who he relies on and we rely on to do great informatics research. So that's a lot of people. So what have we all been doing? Well, we've been writing and collaborating. Here's a network map of some of the people that I work with in concentric circles, those concentric circles I talked about in the video. I've had the privilege of co-authoring with 948 people across time. Many of them, that's a bit of a fudge, if I may say, Chair Gillian, that's a bit of a fudge because many of them have authored a chapter in a book that I've edited. So they're co-authors technically, but anyway, that's a lot of people that I've learned from and had the benefit of their expertise. We also have been collaborating internationally, myself and colleagues, and I tried to count those, but I've lost count. There's too many people and institutions that we collaborate with internationally at the institutional level. And I've had a lot of funding. I've been very successful with colleagues at earning a lot of funding. It looks like a lot of money. However, I just want to quickly say that in case you think we're rich, it's all been committed to research and spent. So you can't hit me for a loan for your mortgage to pay Sidney house prices, okay? That's not feasible. What about research highlights? Let me just hit some treetops with that, because obviously that's a lot of work and I can't report on all of that. One is the idea that we are in wealthy countries, but we also need to involve low and middle income countries. Most of us on the line, and most of us are Australians, are on the call because it's nighttime in many parts of the world. So I've been series editing with colleagues, a series of books on health reform across the world. And there's 3 of those. And that allows low and middle income countries to tell their stories about their health systems. And Gillian, I guess if you were health minister again, this would be really very interesting for anyone who's trying to reform a system as complex as New South Wales, when we've got access to all the different parts of the world and how they're traveling with their reforms. The other thing I do is I'm series editor with a couple of very important people, Eric Hollnagel and Bob Weirs, who's ultimately died, unfortunately, in the US, but other people, and we do work on resilient healthcare. This idea that a health system can flex and adjust and deal with anything that we throw at it, including a pandemic, and it still flies, it still works. And so we're actually up to 6 books. You know, when you're on a good thing, keep on doing it. And we're up to 6 books on resilient healthcare, exploring how health systems, including ours in Australia and ours in New South Wales, is resilient and effective. Some research projects, very briefly, that I'd like you to know about, and you could ask me questions in the Q&A about. One is how much of care is in line with evidence and guidelines. This is our quality of healthcare in Australia for children in Australia study, the care track, one of the care track studies. And the answer is about 60% of care is in line with level 1 evidence or guidelines. So it's good, but room for improvement. And also, you look at that 60 number, a couple of other numbers are 30% of what healthcare delivers could be improved because it's some form of expenditure that we could do better with. Some people call that waste. Test results that don't get seen, and a care that shouldn't be delivered, in fact, or care with marginal value. And, you know, New South Wales and many other places are working on that. And 10% is harm. That's where adverse events befall patients. And although New South Wales has made a lot of movement there, especially under Gillian Skinner's term as health minister, there's room for improvement. There's always scope for this to be a journey. Another thing we've been doing is looking at healthcare as a complex adaptive system. Now, I know that's academic jargon, but what it means is it's not simple to just say, let's do X and Y will occur in a health system. Let's just issue a new policy and it will be taken up uniformly. It's always more convoluted, intricate, and negotiated than that. And this is a white paper that we published that explains that in more detail. And it's a freebie. You can go online and download it from our website. Another thing we've been looking at is what's the future of health systems to 2030? 10 years from now, how will health systems be if we do well? And what about if we don't? Some health systems will do well. Some health systems will do less well. That's a roadmap for the future. Another one, very early in the pandemic, we looked at 40 countries and said, how are they traveling immediately in the first few months of the pandemic, and published a paper on it. Again, you can talk to me about this if you wish. Another study we did very early in the pandemic is we surveyed people in 90 countries and said, how are you coping with this? And there was a big call for more PPE, personal protective equipment, and vaccinations hadn't been even released by then. And testing was only in its infancy. People hadn't set up in many countries testing. But of course, as we know, Australia did very well comparatively. Although we do have a large island with sharks circling it, and we can lock down. Many countries, say in Europe or Africa or Asia, can't do that. They're not ocean locked like we are, so they can't close their borders. Other research we do, we look at how care is networked and connected. And so here's some work we did in Eastern Sydney on a collaboration of researchers and researchers and oncologists, people delivering cancer care. And that's the network in 2012. And that's the network we created by 2013. And that's the network by 2015. This is funded by Cancer Institute of New South Wales. And that's the network by 2017. And that's the network by 2021. So we've created a network. This is very powerful longitudinal research showing researchers and oncology staff getting together to try and produce more evidence-based care. Another one, similarly, we created with Australian Genomics under Catherine North's leadership. That was what Australian Genomics looked like. Circles of people that connect, the lines are connectors. That's the network before Australian Genomics went live. That's how many people we gathered in the first couple of years. And that's what the network looked like 2 years later. This is real success in having researchers being embedded and working with the people who deliver the care. So enough about me and us. What about you? You know, you're going to meet 80,000 people in your life. You have on average 40,000 people left to meet if you're halfway through your life. Some of us have less people yet to meet. You influence them and they influence their 40,000. Multiplied, that totals this number. It's 1.6 million. Do it one more iteration and everyone else meets their 80,000 and you've got 64 trillion opportunities to influence people. 64 billion. There's only 7.8 billion people in the world. So you can have connected via your influence with everybody in the world. That's called leverage. Pretty soon, with one or more iterations, by the way, you'll have a number bigger than all the atoms in the universe. So everyone here on this call is an unbelievable influencer. Together, we are a multiplication force to be reckoned with. And that's why organizations, by the way, like the AHHA are so important. You can make care safer and better by exercising this exponential influence. You can be what I like to call a maven, or a cosmopolite, or just simply a networker par excellence. So how are you going to realize this potential? Answer one, as a leader. Even if you aren't in a formal leadership role, you have the power to exercise leadership. Answer two, as a motivator. You have more power to inspire than you realize. All of us do. So you have the power to be an influencer, plus a maven, plus a cosmopolite, plus a networker par excellence, plus a leader squared, plus a motivator cubed. Power, change the world. That's what that equals. Or you can put it in a formula. Hey, I'm a professor. Influence, plus being a maven, plus a cosmopolite, plus a networker par excellence, plus a leader squared, plus a motivator cubed is power to change the world. Power to change the world, that's the Braithwaite equation I hereby bestow on you this afternoon. It's an equation for you to solve each and every day. I'll leave that with you and finish with a poem. About 100 years ago, during the last global pandemic, the Spanish flu, there was a poem by Guillaume Apollinaire that really strikes me as being important for all of us. All of us charged with responsibility to deliver better care to patients in our influence and network. Guillaume Apollinaire said, "Come to the edge." We can't. We're afraid, they said. Come to the edge. We can't. We will fall. Come to the edge. And so they came. And he pushed them. And they flew. So your mission, my mission, our mission, is to go out and influence, network, lead, and fly. Thank you very much.
Thank you very much, Jeffrey, for your insights and a very, very brief synopsis of your outstanding contribution to healthcare systems in Australia and your work on quality systems internationally. Colleagues on the call, you have an opportunity to ask questions of Jeffrey using the Q&A function. I'm going to take the right of the moderator and be a bit cheeky and ask the first one, Jeffrey. I was really fascinated by the network work you did in cancer care and the complexity of that network over a period of time and bringing a whole range of clinicians and researchers and practitioners together. I guess in the last few years, our capacity to physically network has been challenged by the impact of the plague. Do you have any pointers for how we can maintain our network with our colleagues and how we can also assure in the busyness of that network, we remain absolutely anchored to the fact that we're here to provide the highest quality care to our consumers, to our patients? Have you got thoughts on that, Jeffrey?
So one of the interesting things during the pandemic is we've learned how to interact through pixels, haven't we? We've learned to interact digitally. The health system has with telehealth and telemedicine. It's not the perfect panacea. You know, I do worry about clinicians seeing patients face to face and getting a history and really seeing what they look like, and clinicians are telling me that. They're telling everyone that. We've learned to pivot, to use a modern management term, to overcome the problem that we can't connect. I don't think personally there's a good substitute for face-to-face, and I can't wait to get back to conferences and be able to go to a politician's office or a colleague's office and chat the way we used to in the old days, Gillian. I don't think there's a substitute for that, but I think we've done a pretty good job in Australia and in other countries at trying to overcome that. One of the things I would suggest to people, if you're after suggestions from me, sometimes I get an email. I'm at my desk, at my laptop, and I get an email, and I realize this is quite a long email, and I'm going to have to write quite a long email back. So sometimes I immediately pick up the phone and ring them. This saves us both time and keeps us connected. And it's amazing what people say. They say, "That's amazing you called. I just sent you an email." And I'll say, "I know, that's why I'm calling." So it's a time-saving device. Now, people don't think about that. They think, "Oh, I've got to ring someone. That's going to take time." It's actually faster than writing a long email. And so finding ways to keep connected by Zoom, yes, Teams, yes. But now that we're coming out of lockdown and going into face-to-face, enjoying face-to-face again, albeit with masks and social distancing and all the smart things we've learned to do, but also even taking the trouble to call a family member or a colleague or a patient if you're a clinician. It's a very strong thing to do.
Great. Thanks, Jeff. I'm going to try and do justice to a question that we've got here from a participant. I'm going to use the word global village because I think that sort of segues to the way in which you presented to us, Jeffrey. Their point is, do you have any ideas or suggestions for us in how we can maintain efforts to ensure the developing world, has appropriate access to vaccines, which they're suggesting then have a benefit to us, as in Australia?
You know, there's a lot of contradictions and conflicts and mutually exclusive things go on in healthcare, as AHHA knows. Your policy briefs and your work is legendary. I use it all the time. And you know, if there's one thing about healthcare, there's lots of tensions and conflicts. One of the conflicts is many wealthy countries have done very well, including us, with vaccinations. We're hitting the treetops now. We're even now talking about boosters. Yeah. Whilst there are many low and middle income countries that are up to perhaps 10% vaccination. Yeah. So this is one of those contradictions. I'm basically torn. Of course, I want people in Australia to have a booster, and I know governments in Australia are going to do that. They're going to give people a top up and give a vaccination every year if necessary for the population. But the conflict there is, what about giving the vaccinations, the serum to low and middle income countries? Because as some people in the WHO, who I work with quite a lot, have pointed out, we're not really going to be safe as a globe, as the world, unless everybody's vaccinated or has the opportunity. So it's just one of those, John, it's a fantastic question of the participant. It's one of those things that we all should be a bit torn about. I think we could do much more personally in low and middle income countries if I'm wearing my ISQA hat.
Great. Thanks, Jeffrey. I think just touching on or a comment from me, the critical nature of the work that your institute and your sister institutes do, and the relationship that AHHA have through our Deeble Health Policy Institute. You know, I think we forget sometimes that there's a whole range of people often working in basements doing really important work to research issues, to address your 60-30-10 equation, which I have to say I hadn't really seen before. So do you have suggestions about how we can really focus our attention on lifting the 30? Are there certain key things you think as a researcher that are essential elements of success?
So the 30 is to do with care that probably shouldn't be given, or it's over-servicing, or it's test results that never get seen, so why did we do the test? Or it's or it's administrative costs that are channeled into excessive administration or even bureaucracy. I don't want to demonize administrators and policymakers who do a great job, but that could be deployed elsewhere on the front lines for care. So that's what the 30 refers to. So this is very difficult. Large health systems have become very complex and need to be administered and governed. It's very hard to tap clinicians on the shoulder individually and say, don't do that care. It's not really called for, or it's not quite in line with the guideline, or it's not based on level 1 evidence. But the size of that problem is huge. There's 33 million papers, John, in PubMed. There's 75 randomized trials and 11 systematic reviews published every day. John, you haven't seen the 60-30-10 paper. I'm surprised at you. The Institute only publishes about 250 papers a year and a couple of books. Well, what have you been doing with your spare time? So I'm kidding, of course. That volume almost defeats us, and we do this for a living. Yeah. We're not, by the way, in a basement. We're nicely on the 6th floor overlooking the leafy North Shore. So, just I want to correct you.
That's all that money, right? The money's giving you a view and a window.
I just want to correct that, that stereotype of us in the basement. So this is a very tough problem. Can we do more? Yes. And are health systems doing more? Yes. The shift from volume to value. Do we deliver value for the care rather than just treat more patients without really reflecting on that or restructuring things? Getting test results fast while the patient is still in hospital to the clinician, so that it's not a wasted activity. Seriously looking at administrative burden and overheads and thinking, can we streamline? Can we make it a more streamlined system? Gillian, you'll know that these were things that were perpetuals for you during your time. And you also knew, because you did the shadow Minister for Health and the Minister for Health longer than anybody else, that these are wicked problems. They're not problems that can be solved on the turn of a dime. You did a lot of baseline work to try and tackle this in New South Wales. And New South Wales does probably better than most places. But the other health systems are all striving to, not only in Australia, but around the world, to try and continuously reform and tackle problems like this. There are no perfect solutions, but I do think we provide Joanna Westbrook, Enrico Coira, their groups, who I didn't get a chance to talk much about their work, and our work tries to underpin and put evidence in the hands of people who can make decisions to reorganize and streamline healthcare. That's what we do.
Thanks, Jeffrey. Question now from Chrissy that probably follows on well from where you've ended. And she's asking, could you tell us what motivates you to be involved with improving care in low, middle and high income countries? So where do you focus and why? What drives you?
So this is, I guess, encapsulatable in a word, isn't it? It's the equity word. One of the things we've all seen during the pandemic is if you're middle class or downright wealthy in a lucky country, a country not just lucky, that's got resilience and hard work and systems that work and an educated population, you do relatively well. So within countries, there are inequities because other people don't. And then across countries, there's huge inequities. The best example of inequity within a country is probably the US, which we all see on our TV screens all the time. If you look at their health system or their wealth distribution, there's major disparities. We can just do better than that. Australia's a bit more egalitarian, but perhaps some people feel it could be more so. We could do more to help lift people up. But it's even more marked across countries. If you go to low income settings, like I've sometimes been to with ISQA and to provide a helping hand, they really don't have much. What is it? A third of the world live on $3 a day or less and are basically subsistence farmers.
Yeah.
So, that makes you get up in the morning. That if the question was what motivates you, even making a small contribution to that is not a bad thing to be doing. And it's a privilege for me to be part of that and to be part of ISQA and working with WHO and other groups who really do the hard yards there.
Thanks, Jeffrey. Another question from a participant is apparently they know a little bit more about some of your specific research than I do. So around your engagement with ICU projects in the US and the delivery of care by the clinicians to patients during their, it says here, during their daytime, I'm assuming while they're awake rather than while they're asleep.
Yes.
They're just asking if you could give a little bit of an oversight of what the benefits of that project or learning from that project were in terms of critical care.
Yes, so this was, Enrico was mostly involved in this. I think it was his project and a couple of other people in our faculty. So it's, you know, the innovation in Australian in our title, Australian Institute for Health Innovation. We try and think outside the box. And sometimes we have great times here just saying, you know, could we do things differently? So one thing is, you know, patients in ICU, they need to be monitored. But do you have to be there all the time? Or can you complement what happens at nighttime when patients need to be monitored by a different part of the world where it's daytime? So we ran a project. And so what happened was here in this building that I'm in, we had a monitoring project where we were monitoring ICU cases, intensivists, intensive care specialists, monitoring ICU patients in American hospitals. And it, you know, if you realize the Earth is round and it goes through daylight and nighttime at different times for different parts of the world, you realize you can think outside the box and think differently. So that's, you know, I'd credit, that's not me, that's Enrico and other smart informatics and Joanna Westbrook and other smart informatician type people who are thinking outside the box, because we really are connected and we don't have to be we don't have to be in the same place at the same time to work together.
Very, very good. And you're absolutely true. I'd love to see what the sort of payment schedule looked like if it was in the US hospital. It must have been pretty groovy, hence your view, right? Anyway, if we could stay a little bit on that thematic, right, of this virtual world in which we're entering, and we've seen, I guess, about a decade's worth of change in telehealth in 2 months during the plague.
Yeah.
And your sort of niche or focus on quality, are there certain anxieties you have around the pace of that change and the implementation of telehealth, which I think brings great value to our consumers? But do you see any inherent risks in terms of the quality? And I think you touched on it in your speech.
Yeah, I did. I tried to touch on that a little bit. So yes, it's a problem, isn't it? It almost, who's that famous economist who said, you know, there's no such thing as a free lunch? Nothing comes absolutely magically with a total solution and there's no consequences, no adverse consequences. So nothing's totally free. It's got to be worked out. So in this case, obviously, being able to see patients at a distance, not having people travel, doing telehealth and telemedicine, doing consultations, it saved a lot of spread of the epidemic. The pandemic did not spread in Australia as much because we went to telehealth and telemedicine. No, most countries did, where they had the capacity to do that and see patients remotely wherever possible. That's what they did. Everyone pivoted on the turn of a dime within a couple of months, as you say, John. However, there's some consequences to that. What about the quality of care? Can you can't do surgery that way. Well, you can with a bit of robotics, but, you know, you still need a theatre and there's still, you know, you can't just do surgery on people in their homes, okay? So there's limits, firstly. And then the second thing you've got to think about is, what about the quality? When I visit my GP through a Zoom or through a phone call, I'm a little uncomfortable that they're not getting the full picture, only what I'm verbally reporting. And they're not seeing me and my healthy glow or my unhealthy glow and what are the symptoms. And, you know, one of the things about clinicians is they're really good diagnosticians when they see you face to face. Many of them are, especially in their area of specialty and especially GPs. So we have to think about when to use technology appropriately and still maintain quality of care and safety for patients. And so we've been doing a lot of work thinking about that. So as I said, there's no panacea, there's no magic wand for anything, but we are making very good progress. And it was fantastic that we went to telehealth and telemedicine and remote consultations and monitoring so fast.
Great. Look, questions flowing in from participants, which is good there. I'm going to try and stitch them up if I can, but they're going to dance around a bit, Jeffrey. I apologise. Another question here around climate change, obviously being quite topical in the last few weeks with COP and whether or not we should eliminate, eradicate, reduce or ignore coal. Could you speak a little about the challenges for the Australian health system that you see in relation to the impact of climate change, or our approach to how we in fact contribute to climate change, either one?
Even better, John, I can point to the 4th of December when we're going to run a seminar out of the Institute with some of the key people who've done work not just on climate change, but climate change and human health. So there's lots of consequential effects for a warming planet to Australia. Water and drought, bushfires and adverse weather as a consequence of the climate is one thing, but risks to human health, burning coal is not good for the environment and for particulates in the atmosphere. A warming country and a warming planet means more opportunities for disease, vector spread disease, malaria, marching malaria, all sorts of things are prone to be intensified as a consequence of a changing climate, a warming planet. And Australia is on the front lines there because are we the driest continent? People report that we're the driest continent. Although we've got lots of natural resources, we don't have enough water, and we are on the front lines in terms of bushfires, etc. So, tackling the climate is not just in our national interests, it's in our international interests. So we're going to be conducting a major webinar and discussion on the 4th of December, 2nd of December. And one of my team has just circulated details of that on the chat line, John. Just
right.
so this, who says researchers are slow and ponderous? We're doing this in real time for you, John.
Thanks so much, and we'll amplify that through our channels, I'm sure, given that we're active in the climate and health sphere with a number of partners. So that's great. Obviously, you've got a great fan here who's decided to remain anonymous, who talks about your great presence and communication abilities, which I concur. And that person is asking if you have advice on how we can all tap into your potential to change the world motif, particularly in relation to health policy.
So, two answers. One is, I think everybody has more capacity and latent power than they think. As I said in the slides, even those who aren't in a formal leadership position, they're not a minister or a secretary of a health department or a key opinion clinician, you have concentric circles. My concentric circles thing was a metaphor. It was a description of me and my team and my colleagues, but it was also a metaphor for everyone. So you have far more capacity to influence than you think. And sometimes it just behoves you to go and do it. Just do it, like in the Nike ad. So that's one thing. I try always to empower people to have agency as much as I possibly can. The second thing is, you've asked about policy. This is a very difficult area. One of the things we've done, which I think is, and policymakers recognize this, is we've probably created, in some health systems, too many policies. It's sort of like, there's a problem, better fix it, issue another policy or procedure.
Or a plan, maybe.
Or a plan, yes. And I wonder if we haven't overdone that in some health systems that I see. I wonder if we couldn't have a rule, for example, that every time we do another policy, we have to take one away, or even two away, and reduce and streamline the number of requirements for people on the front lines. I wonder if that would not lead to more, a better healthcare.
Cool.
I once proposed a randomized trial in a health system, and it went nowhere fast. Let's reduce all the paperwork and bureaucracy in one part of the system randomly in some hospitals and leave the others with their level of bureaucracy, and let's see if we could have a control group versus a intervention group. But no one wanted to fund it, unfortunately.
Yeah, I'm sure. Listen, look, great insights, Jeffrey. Thank you so much. I'm going to ask one last concluding question, and it comes from what I think might be an aspiring young research person who is asking for pearls of wisdom from you about what you would give them as your one piece of key advice to an aspiring researcher. Hoping to change the world, he says.
One, well, mentors, I mean, there's lots, but mentors comes to mind. Having people who will help you, who you respect and who respect you, and can mentor you along the way on your journey. It won't be the same mentor for all of your journey. That will transition across time as you transition across time. But having one or two people who help you, let's call them, they're your mentor and you're their mentee, I think is empowering.
There you go. Get yourself a mentor, Tom. If you're still paying attention, hopefully you are. Look, we've run out of time, unfortunately, Jeffrey. It's phenomenal to hear you reflect on your outstanding career. Once again, I'd like to congratulate you for your contribution to our industry and the lasting impact you've had now and will continue to have. I hope this has been a helpful session for participants to hear some of the musings of an esteemed health researcher. Thanks to everyone who's joined us today. To find out more about the Sidney Sachs Medal or the work of the Australian Healthcare and Hospital Association, visit our website. My tongue will work in a minute. We look forward to your participation in future activities, and we are a mechanism by which you can become part of that global campaign to have an impact. So we look forward to hearing from you, working with you, speaking to you, and learning from you. Thank you all so much for joining us. Congratulations again, Jeffrey, on the award. Hope everyone enjoys the rest of the day. Thanks so much.
Thank you, John and Gillian. Thank you very much.